Hello, I'm Professor Barbara Yawn, a professor of family and community health at the University of Minnesota, Minneapolis in the United States. I am joined today by Professor James Chalmers, who is a consultant respiratory physician at the School of Medicine, the University of Dundee in Scotland. Welcome, James.
Thank you, Barbara. Lovely to be here.
It's lovely to have you to talk about the pathophysiology and the comorbidities of non-cystic fibrosis bronchiectasis. We're going to just say non-CF bronchiectasis. So let's start, James, by what is bronchiectasis and how would I know that someone has bronchiectasis?
So thanks, Barbara. So the disease bronchiectasis describes a combination of widening of the airways. That's what bronchi and ectasis. Bronchi is the airways, ectasis widening. That's what the disease means. But it's also a clinical syndrome, and it's a clinical syndrome defined by cough, sputum production, and recurrent chest infections. And so we recognize these patients as patients that present to us with those symptoms. The difficulty comes that those symptoms overlap with a lot of other diseases that we see in practice, like COPD and asthma. And so you need a high index of suspicion in order to recognize patients with bronchiectasis.
Well, how common is it? I mean, a lot of people say, well, I don't think I've ever even seen anybody with bronchiectasis.
That's probably one of the key messages for this session is this isn't a rare disease. It used to be classified as a rare disease, but the prevalence has really increased over the last several years, such that it's now considered quite a common disease. So the prevalence estimates now in Western countries like the UK or the US are between 500 and 1,000 per 100,000 people. There's probably one bronchiectasis patient for every 18 patients with COPD. So you think about how common COPD is, that means there's a lot of bronchiectasis patients out there. And you're probably seeing some if you're working in primary care, and certainly if you're working as a pulmonologist.
Well, and obviously, if I don't think about it, I'm never going to see anybody. And so that's what this is all about, is to help us think about what we would see. And you commented on cough, but gee, that sounds a lot like chronic bronchitis. How is this different? How is the presentation different?
Yeah, so patients will generally have a productive cough. So that's usually more persistent, usually lasts all year round, and patients may have respiratory tract infections. So the classic patient would be coming to the general practice 2 or 3 times every winter, having chest infections. How it differs from things like COPD and asthma is, I mean, asthma patients tend not to produce a lot of sputum, and people with bronchiectasis are often diagnosed after they fail to respond to asthma therapies. Likewise, in COPD, you have to have a high index of suspicion because the presentation can be quite similar. But think about bronchiectasis in patients that produce a lot of sputum, a lot of purulent sputum, but also in patients that have not responded well to therapy. And particularly, I continually see patients who've never smoked and get a label of COPD because they've got a cough and sputum. And when you scan those patients, they've actually got bronchiectasis and it's a misdiagnosis.
The treatment for bronchiectasis, which we're not going to talk about much today, but is very different than for asthma or COPD because the pathophysiology is different. So, if I have somebody that I've called asthma or COPD and they're not doing well, I better start suspecting bronchiectasis if they have a lot of cough and sputum.
Yeah, absolutely. So this is gives us a little window into the pathophysiology here. So, an asthma patient we treat with inhaled corticosteroids because that's a disease where these cells called the eosinophils dominate in the airway, and inhaled steroid are very effective against that type of inflammation. Bronchiectasis is driven by a vicious cycle of infection, which creates a neutrophilic type response, so very different to asthma, and impaired mucociliary clearance. And that neutrophilic inflammation doesn't respond to steroids. And so Often my patients with bronchiectasis will say, I was given this asthma inhaler, I tried it for a year, it did absolutely nothing. And that is a really good clue to, oh, this isn't typical asthma. Maybe I should be thinking about bronchiectasis.
Well, and with COPD, this is also not reversible bronchospasms. So the usual bronchodilators aren't going to help either. So you treat them that way and they don't get better, right?
That's correct. So some patients with bronchiectasis will have airflow obstruction, and so they might feel a little bit better with bronchodilators. But much more the dominant features in bronchiectasis are the cough and the sputum production, which the inhalers will have no effect on, and the requirement often for multiple courses of antibiotics for the chest infection. So that's a way that you can differentiate it from typical COPD.
So, what about sputum? How is it unique or different with bronchiectasis?
Yeah, so patients will cough up much larger volumes of sputum with bronchiectasis. The other thing that I think is really useful, and it brings us back to that point about pathophysiology, Barbara, is thinking about sputum purulence. If you see very green sputum, that suggests the presence of infection. People with bronchiectasis, their airways are colonized with bugs like Pseudomonas, Haemophilus, Moraxella. So if you see very purulent sputum, there's a good chance that that patient's colonized with bacteria, and that makes it more likely that they've got a condition like bronchiectasis. Here's some cool biology for you, Barbara. So what makes sputum green is actually the only green protein in the human body. It's a protein called myeloperoxidase, and it's made by neutrophils. So going back to that difference in the pathophysiology between asthma and COPD and bronchiectasis, in bronchiectasis, it's very neutrophilic. The lungs are full of neutrophils. They take this green protein in there and they turn the sputum, yellow initially and then bright green. So you see lots of green. That means there's lots of myeloperoxidase. That's your body's natural infection detection system. But it also gives you a clinical clue that you should never see bright green sputum in an asthma patient. So you should be thinking, oh, this could be bronchiectasis.
So, it's important to ask about the amount of sputum, when they produce the sputum, like all year round, and what color it is.
Yeah, and also think about sending sputum cultures. So they're incredibly useful. If you identify, for example, Pseudomonas in a sputum culture, that patient's probably got bronchiectasis. Even in my difficult COPD patients, I send off sputum cultures because they're extremely useful.
So, what other things we've talked about asthma and COPD? Are there other comorbidities associated with bronchiectasis?
Yeah, so probably the other really critical question you should ask yourself if you've got a patient with bronchiectasis is, why has my patient got bronchiectasis? So I've mentioned already this vicious cycle or vortex of impaired mucociliary clearance, inflammation, and infection. Those three things are how patients arrive at the disease. So some patients have severe infections like a bad pneumonia that leads to bronchiectasis, or they're susceptible to recurrent infections because of things like immune deficiency. Some patients have a genetic cause, cystic fibrosis being the most famous, but there are other causes of impaired mucociliary clearance that are genetic. And so in young patients, we have to think about that, remembering that bronchiectasis can affect anybody from children up to older adults. And then on the inflammation side, inflammatory conditions like rheumatoid arthritis, inflammatory bowel disease, connective tissue diseases, allergic bronchopulmonary aspergillosis are all quite common causes of bronchiectasis. And so knowing these associations are important because you should suspect bronchiectasis if patients with these conditions present with cough and sputum, but also they have a big impact on patients' quality of life. And so the management needs to take into account not just the bronchiectasis, but the other things that our patients have.
Well, and sometimes we might get focused on the rheumatoid arthritis and the joint pains and say, oh, well, yeah, they just have some problems with some infections, lung infections. No, wait a minute. That's time to stop and think about they could have, in addition to their rheumatoid arthritis or lupus or whatever, they could also have bronchiectasis.
Yeah, so in clinical practice, we use a lot more immunosuppressive drugs now for a lot of different conditions, don't we? And so if we see patients that are taking those medications who then develop repeated problems with their chest, that's a very common presentation now of bronchiectasis. So don't just say, oh, that's the drugs and that's just the way it is. Think about, has this patient now developed bronchiectasis as a complication?
So I think those are all important points that we as primary care can remember. Ask about mucus, ask about the color, ask about the amount and the duration. And thank you so much, Professor Chalmers.
Hello, my name is Professor James Chalmers, and I'm a consultant respiratory physician at the School of Medicine, University of Dundee in Scotland. And I'm delighted to be joined today by Professor Barbara Yawn, who's from the University of Minnesota in Minneapolis, USA. And I'm also thrilled to be joined by Marta Almagro, a person living with bronchiectasis. So welcome to both of you.
Thank you.
In this section, we're going to cover the clinical presentation of non-CF bronchiectasis. So, Marta, let's start with the symptoms. So, on a daily basis at the moment, how does bronchiectasis affect you in terms of your symptoms?
So, I had my bronchiectasis since I was a child, and it wasn't until I got my colonization by Pseudomonas that my symptoms have been worse. My sputum is always kind of yellow greenish. I have a lot of cough. I have frequent voiceless episodes, and also with my sinusitis, it's all a bit complex.
Yeah. And how do things change when you get a chest infection? Because I guess exacerbations are the other part of the disease that we're talking about today.
Yeah, well, that has also evolved during the years, because when you are young, you manage yourself in another way, and also your body responds in another way to antibiotics and also to the infection itself. But now it's more difficult for antibiotics to uh, get me better. And also my chest congestion, it's worsened with the time. So maybe now I'm not just with purulent mucus, but with a very tight chest. And then after 3 days, then my sputum comes really green, and it a lot of quantity. So it varies.
Yeah. So Barbara, thinking about the patients that you see, Marta's story must ring a few bells in terms of familiarity of the symptoms of bronchiectasis.
We see young patients and they have recurrent infections, and right away you think, oh yeah, that's because I missed their asthma. But we are talking with Marta, and your symptoms are not just a little bit of an exacerbation. You're talking about severe lower respiratory tract infections and lots of sputum. And I don't see that in young children very often. So that was really important for you to remind all of us when we see a young person, 2, 3, 4, 10, 12 years of age, and they're having all of this cough and sputum, and you look in the medical record and you see, oh my goodness, they've been to the emergency room or even the hospital. I better start thinking of not just asthma, but beyond asthma to bronchiectasis.
Yeah. Would you say that Marta's presentation, what she's described, is quite typical? And is there any other features that you would tell our audience to look out for?
Well, quite typical is obviously difficult when you're a primary care physician, because I don't see many young people with bronchiectasis. I don't know what else I should look for. What would you suggest, James?
Yeah, so I mean, I think the description of cough, sputum production, chest infections that don't settle or partially settle with antibiotics are quite important. Other things like breathlessness, which we might ask Marta about in a moment, and coughing up blood is the other thing that patients who cough up blood should immediately be an alarm bell that this needs further investigation. Are there any other symptoms, Marta, that you think that we should be telling people to look out for?
Yes, as you said, breathlessness. I wasn't told about the possibility of coughing blood. So it's not an issue for me because maybe I had 4 or 5 episodes in my life. But yes, it's something that it shocks you when you cough blood and you know that you don't have anything like, I don't know, tuberculosis or something like that. And other symptoms that you have to be looking for. I mean, I had sinusitis since I was born too, and sinusitis is sometimes is related to primary ciliary dyskinesia, which I have, and in my case, it's the etiology of my bronchiectasis. So there are hints here and there that you may want to look for.
Marta, I was going to ask you about weather changes. I mean, as we go from a very hot summer to a very cold winter, are these problematic for you?
Always, and more with the age. It's not the same when you are, as I said before, you are a young person and you're healthy and your system is more efficient and reliable. And it's not only that you don't manage it well with the years, but it's also that the changes in the climate are more extreme. And also, it's really important to think about the pollution, because I live in Barcelona, and when there is a lot of pollution, I also have to keep me indoors the most of the time, because otherwise I get an exacerbation.
Yeah. I want to talk a little bit now about the pathway to diagnosis, because that's, I think, really important. For you, Marta, how easy was it, or how long was the journey to get a diagnosis of bronchiectasis?
13 years of
Wow.
of my life to get to a diagnosis. So I was born with colds, and I mean, since 2 months that I was born, my mom always tell me that I had colds, a lot of cough, sinusitis, recurrent bronchitis, and I had an aneurysm when I was 2 years old. My pediatrician didn't know really well what was happening to me, so they referred to my parents to another pulmonologist, pediatrician pulmonologist, and she knew something more about it, but there was not an easy question and not an easy answer. So they referred me again to a hospital clinic in Barcelona that at the time were treating children, and they had a really pioneer respiratory pediatrician team. They knew something that was going on. They did to me saccharine test to see if there were involved my cilia. They also put me to a lot of radio diagnosis, like simple REX, but also another nuclear diagnosis imaging that went on during the years. But in the meantime, I got 2 pneumonias, and I think it was the second one. Then I got a chest infection so bad that it got me love medium syndrome. So I had to underwent surgery to remove it. In the biopsy, they write down that in my way compatible with bronchiectasis, but it wasn't until I was 13 years old when I was finally diagnosed with primary ciliary dyskinesia through bronchoscopy and also of bronchiectasis through a CT scan. So it was a long journey with a lot of tests of all kinds.
This had to be so frustrating for your parents, not just you being ill, but your parents. They keep bringing you in, and we as the healthcare community, sort of treat the little problem here and then you go away and we may forget about it. So when an example of really listening to the parents and understanding their frustration. And when somebody has this level of frustration, that's one of my first warning signs of, I need help. It's not just the patient needs help. I, as a physician, need help. James, this is when I'm going to send somebody, I hope, to you and say, help.
Yeah, so I mean, Marta's, I think, really powerfully describes the impact of delayed diagnosis there, but it's not, delayed diagnosis isn't just limited to children. I mean, in studies of adults, the majority experience symptoms for more than 10 years before they get a diagnosis of bronchiectasis. So this is across the spectrum of bronchiectasis. So we need to think about how we increase the diagnostic rate, increase the awareness. And that means it's you and me, Barbara. It's thinking how between primary and secondary care we can join up that diagnosis and try and make the pathway easier. Because I think Marta's powerfully told us the impact of when we don't get that right. So can you think of, as the final word, Barbara, do you think there's any key messages we can give in terms of improving the diagnosis of bronchiectasis?
Well, I think the recurrent nature of the symptoms is really, really important. I mean, these are recurrent episodes of infection, of cough, of sputum that are way outside the normal of what kids or adolescents or adults or older adults get. This is the time to say, I'm suspicious something else is going on. Let me ask someone else to help me, and make the patient a partner in this. Make sure I understand the impact on them. So ask, listen, and be suspicious. Ask for help.
Yeah, and that's a great message to finish with. So thank you to Barbara and Marta for this really fascinating and important discussion around the symptoms and diagnosis of bronchiectasis. And I hope you can join us for some of the other episodes in this series.
Hello, I'm Professor Barbara Yawn, a professor of family and community health at the University of Minnesota in the USA. And today I'm delighted to be joined by Professor James Chalmers, a consultant respiratory physician at the School of Medicine at the University of Dundee in Scotland, and also Professor Mary Salvatore, an associate professor of radiology at Columbia University in New York in the United States. And especially we're pleased to be joined by Miss Marta Almagro, a person living with non-CF bronchiectasis in Barcelona, Spain. So welcome to all of you. Today, we're going to be discussing approaches to the diagnosis of non-cystic fibrosis bronchiectasis. So let's start with, how do we think about this? Now, I, as a primary care physician, am saying, gee, I am suspicious something else is going on. There's lots of cough, lots of sputum. There have been several infections. my first step is going to be to come to you, James, and say, help, there's something going on and I don't know what it is.
And so in my clinical practice, the presentation you've just described, that's classical bronchiectasis. The first diagnostic test that I would be thinking about is the HRCT scan. In practice, many primary care physicians will do a chest x-ray before going to the CT scan. But it's important to remember that while the chest x-ray helps to rule out some other things that can cause respiratory symptoms, it's not sensitive enough to rule out the presence of bronchiectasis. So in the history that you've described, my advice to you would be this patient's going to need a CT.
When you send the patient off for the CT, I know one of the things that my radiology colleagues say is, please make sure you tell me what you're thinking. Don't just say need CT scan. Mary, what would you like us to say and what would you do?
I'd like to think, ask the clinician to say what their differential diagnosis is. So that helps to clue me in on what to look for on the CT scan. I look at the patient's age, I look at their gender. That helps give me some information about the differential, but what the clinician has seen clinically is most important to me.
And Marta, you went through all of this process. When did you finally get a CT?
When I was 13 years old, after 7 years of I underwent surgery, and it was thanks to the CT scan and also bronchoscopy that I was diagnosed.
And so you had the CT scan. I know you'd had many chest x-rays already. What other kinds of tests did they do beside the CT scan?
Pulmonary function testing, also spirometry and blood samples, sputum samples. It was a mix of all. Also, immunodeficiencies test, and so on.
So many tests to try to figure out, was this bronchiectasis but then tests to figure out why you might have bronchiectasis.
Well, it was a bit of both at the time because I was a child. So they were trying to see the cause, and maybe seeing the cause, then they could diagnose what I have. It was a bit of both.
Yes. And one of the things we haven't said yet is that, of course, if we're suspicious of this, especially in a child, we're going to check for cystic fibrosis. None of us have said that, but that's one of the first things we obviously will rule out, is that you don't have cystic fibrosis. It sounds like the CT scan is really central to this diagnosis. Mary, what do you see on the CT scan that's going to help us?
So the CT scan, we can do it without contrast, and we do axial images through the chest, very thin cuts. When a patient comes with shortness of breath and cough, I'm going to look to see if there is pneumonia. But then when I see the bronchi that are bigger than their accompanying artery, I know the patient has bronchiectasis. So radiographically, the diagnosis of bronchiectasis is an airway that's bigger than the artery that it's traveling with. And when I see that and it's persistent over time, then I know that there's bronchiectasis. But many diseases have bronchiectasis. So then I have to think about which disease is causing the bronchiectasis. And that is, I do that based on the pattern of the dilated airways. If there is just one dilated airway, it has a specific differential. But as in many patients, it's multiple airways. And then the best thing I can do to help me is say whether it's mostly in the upper lungs or mostly in the lower lungs. Marta, your CT scan, I can imagine, had a lot of lower lung bronchiectasis, which is characteristic for primary ciliary dyskinesia. Whenever I see a young person with lower lung predominant bronchiectasis, that's number one in my differential. Usually they'll have a history of recurrent pneumonias. And I'll suggest to the clinician that they should test for ciliary dyskinesia. Sometimes in the lower lobes, you can get bronchiectasis from aspirating. If people's esophagus is not working well, they might get lower lobe bronchiectasis. But the pattern is what really helps me to narrow my differential radiographically.
Well, and that's really interesting because I think most of us in primary care, Mary, would assume you're just going to say, yes, it's bronchiectasis, or no, it's not bronchiectasis. But you're saying you're going to be able to go way beyond that and suggest potential etiologies we need to look for.
Yes. And then on follow-up visits, whether it's getting worse on treatment and if treatment should be changed is another thing that I can provide with the interpretation of the CT scan.
And I think that just highlights the fact that this is all of us working together, because the primary care, the pulmonologist, the patient, and the radiologist all have to give us input to figure out what is it in the beginning, but then how do we know we're making progress or not? One of the things, Marta, I know in primary care, sometimes you feel real concern of, oh, if I make this diagnosis, it's going to be terrible for the patient. This is a chronic, non-curable disease. Is that how you felt about the diagnosis?
Well, I was very little, but it was peace of mind, basically, for me and for my parents. And also that all the tests that I had gone on during the years stopped. And now I had the chance to ask precisely for the right questions. So now we know that we have that I have that. What does mean to me in my future? What treatments are available? How can avoid getting infections and so on? So it's kind of you get relied of all the burden of not knowing what you have.
We're obviously frustrated we're not able to help you, and having a diagnosis is going to help our level of frustration in addition. James, is this what you see when you do help make the diagnosis?
Yeah, I think that's a really crucial message, is that the diagnosis can be life-changing for patients. If patients get onto the right treatment for their bronchiectasis, it can make a huge difference. And as we've emphasized in this discussion, it's both the diagnosis of bronchiectasis, but also why the patient has bronchiectasis, because some of these causes of bronchiectasis are treatable. Of course, we don't want to CT everybody who's got a cough, because there's a cost to that, but we need to have a high index of suspicion for bronchiectasis and be willing to do high resolution CT to make the diagnosis, because it can make a huge difference to patients' lives when we do.
What should I do, and what do you want me to do before the patient comes for their CT? Is there anything special in primary care I should do other than explain to Marta and her parents what a CT is?
And it's so important that they breathe in and hold still, because motion artifact from respiration really limits my ability to correctly diagnose bronchiectasis. So that is very important. And I can use a low dose now. So I would encourage when you refer patients to places to make sure that the radiology is using as low dose as possible to keep our patients as safe as possible.
James, Mary, how often do we do repeat CTs?
Yeah, so I very rarely perform repeat CTs unless there's a major clinical change in the patients. I've got a really low-tech way of finding out how patients are getting on, which is speaking to my patients. So, I only really perform repeat CTs if there's a major change in patients' condition. So that means, a big increase in symptoms. Patients have gone from being stable to having repeated exacerbations. And what I'm looking for then is development of complications. So the patient's now developed an NTM, or they've developed ABPA, or they've become colonized with a different organism, or a different pathophysiology, pulmonary fibrosis, for example, has overtaken the bronchiectasis. So I think we should, because this is a test that involves radiation, we should have a really good reason why we do a repeat CT, and it should really be about a change in the patient's condition.
And Mary, are there any times where you think a repeat CT is absolutely essential?
I think that I agree that the clinical history should drive whether the CT scan is done. In patients with pulmonary fibrosis, the CT scan could be used for screening for lung cancer, and then that becomes something that might be worthwhile. I hope the future will allow us to do MRI for imaging of the lung without radiation, and I am pushing for that in fibrosis and maybe Marta also in bronchiectasis someday. The test is getting shorter. It's now 3 minutes as opposed to 45 minutes, and so it becomes more of a possibility. But it's not there yet. But I believe it will be in the not too distant future.
Well, so in summary, we've heard that it is important to work together to figure out what tests need to be done. The CT is central to the diagnosis. Marta has told us, please go ahead and help us get the correct diagnosis. And Mary has given us a little hope for maybe something new in the future with the MRI replacing the CT and protecting patients from further radiations.